All right. Hey, everybody. Welcome back to Knee Shield. And today we're going to be going through the meniscus. So let's dive right in. Now, I thought it might be nice to have a little bit of a visual here. So let's take a tour inside the knee and really get a nice grasp as to what these structures are, how do they look, and then we'll go through what they do and their structure in just a second. So you can see that we've got two here. So right now you're looking at the medial meniscus that's highlighted on the inside, and we also have a lateral meniscus on the outside. And you can see when I add on some of these layers of connective tissue, just how deeply encased within the knee they are. And they both have sort of a unique architecture to them, which we'll go through in a second. But essentially, as far as their functions concerned, I always refer to these guys as your shock absorbers. The knee is a weight-bearing joint inherently, and so it's constructed as such. Rather than just having the layers of articular cartilage that coat the end of the thigh bone and the end of the shin bone, you have these extra two shock absorbers, your suspension, if you like, encased within the knee to primarily help to absorb load and to protect the joint, to maintain space in there, and to protect and preserve that articular cartilage. So the menisci always sounds weird calling them that, but hey, what can you do? That's the plural. They are built, they are structured, their structure is made of the hard stuff, right? So we've got the three main types of cartilage here. Hyaline or articular cartilage. Now, that's the kind that if you just see that kind of really shiny coating on the ends of the bones, that's what you're seeing. That's that articular cartilage. It's the most common in the body. It's the most abundant throughout the body. It's tough. It's smooth. It's thin. It's kind of bluey white in color due to the lack of blood supply. We'll talk more about blood supply later on. And it's found in essentially all of the joints. And it becomes slippery when lubricated with that synovial fluid. That's just that joint WD-40, basically joint lubrication fluid. And it reduces, therefore, friction between the bones to allow for optimal joint movement and reducing friction there. And this is the one that is most associated with arthritic joints. So if you get arthritis, it tends to be because of a weakening of this type of cartilage. Now, the elastic cartilage, I'm not going to talk too much about that because it's not really relevant here, but as the name suggests, it's got that kind of elasticity to it. In terms of where you'd find this in the body, you'd find it in places like like your ear, which is made up of this kind of elastic cartilage, which is if you just feel your ear, you can feel what I'm talking about, the kind of flexibility that's woven into it. And then finally, the fibrocartilage is the type of cartilage that predominantly makes up the meniscus. Now, it's obviously composed of various different elements. The cells within the menisci are referred to as fibrochondrocytes because they're essentially a blend of fibroblasts, which produce collagen, which is a type of protein, which makes up about 20% or so of the meniscus, and the chondrocytes, which essentially produce the cartilage. There's a high component of water content, and you have these hydrophilic cells, such as proteoglycans, which draw water into the meniscus, and that's part of the property that gives it its shock absorbing ability. In a normal healthy meniscus, tissue fluid essentially represents about 65 to 70% of the total weight. So let's have a look at these menisci in turn, starting with the lateral meniscus. So it's a little bit more circular in shape, as you can see. It also moves almost double the amount compared to the medial meniscus. And there is a potential that is an element that provides some layer of protection. The fact that it's got more excursion potentially gives it less propensity to getting injured compared to the medial meniscus. That's certainly a possibility. An important unique factor here is some of the anatomical attachments that it has. So one of which being the popliteus muscle, or tendon, I should say. So you can see here's the posterior horn of the lateral meniscus, just a fancy way of saying the back of the lateral meniscus. We love to complicate things. And the popliteus being this kind of triangular shaped muscle that you can see here. Now, what it actually does on this meniscus is that when you unlock the knee, when you initiate unlocking the knee or the knee bending, let's say if you go to sit down, it's going to, they often refer to the popliteus as the key to unlock the knee. Now, the way it does that, you'll only be able to see if I show you this next video here. Now, hopefully you can see the tendon up top here. Let's go in a little bit closer and swing around so you can see. So the tendon here attaches to the femur, and if you just imagine it contracting here, it's going to pull and then rotate this femur externally, right? As the knee bends, and it's also going to retract this meniscus back to stop it from getting pinched or entrapped. And that's essentially what it does. That's the relationship that the popliteus has when it comes to the lateral meniscus and when it comes to how it works in that weight-bearing sense. When it comes to the medial meniscus, rather than this circular shape, we've got, I think it looks like an ear personally. That's the first thing that comes to mind, but maybe you see something different. Either way, it moves less. So like I said, about half as much, 5 to 6 millimeters or so, but there is some level of movement there. And as far as the unique anatomical attachments here, one of them I think is key. The deep fibers of the medial collateral ligament, that's just that. So this is the inside of the knee, here's the outside. And you can see, hopefully there, if I highlight it, these portions of fibers that just knit into the disc, the cartilage disc, the meniscus here. So why is that relevant? Well, anatomically speaking then, if you sprain this ligament, there's a chance then that you're going to have a concomitant meniscal injury at the same time. And often the case is that we see this unhappy triad that we refer to as ACL, which you can see here, medial collateral ligament and meniscal injury, three for one, 3 for 1. So this is a really common question. Can the meniscus heal? Is it going to heal if I've injured it? Can it repair on its own? Well, like with most things, it's complicated. But on the left here, you can see this image. Our blood supply to the meniscus unfortunately diminishes as we get older. A is showing you from pretty much birth to year 1. B is 18 months to 18 years old. And then 18 years old plus, you're getting diminishing penetration of the blood supply into the meniscus. But on the right, you can see these different zones. So RR, WR, WW. What that stands for is red, red, white, red, white, white. It sounds like one of those. She sells on the seashore. Would a woodchuck chuck. So that's not what you need to hear, is it? So that gives you this indication of, depending on which third your injury occurs, to some degree, there are other factors like the type of tear, but that gives you some idea of how likely it is that the tear will be able to heal on its own. So the ideal would be to have the tear in the outer third, in the red zone. I'm going to show you just so you can see here on the model. So here are the 3 zones, and this one actually has a tear here. Here's one I made earlier. So this would, you can't see me in quotations here. This would be the ideal as far as having a tear in this third. And again, the least ideal would be in this kind of white zone right on the inside there. So as far as types of tear are concerned, I'm not going to go through all of them in great detail. That's kind of beyond the scope of this presentation. However, that being said, I would like to draw your attention to the vertical longitudinal tear just here. Now, this is an example of the one that I'd showed you in the previous slide. And I did that for a deliberate reason, because again, in quotation marks, the ideal tear, not that any tear is ideal, but would to be one, to have a tear in the periphery, in the outer third because of the blood supply. And secondly, to have a type of tear that's easily reducible. What do I mean by that? Well, if, as you can see here, this is a straight line, as far as surgical procedures are concerned, the easier it is to sort of draw these ends of the cartilage back together, you might be a candidate for somebody who could potentially have a meniscal repair, which is preferable because the ideal scenario is to try and preserve the cartilage as much as possible. Now, it's not always possible, and there are multiple surgical procedures for meniscal tears we're not going to go through now, but you can sort of just logically see here, right? So it would be kind of reduced in this sort of fashion as I'm showing you my cursor here. The more that you have tears that sort of extend through multiple zones, those thirds that I mentioned, or that creates, we haven't marked it here, but a bucket handle tear, which is a little bit similar to this one, which might cause a dynamic flap to lift up and cause actual disruption to the mechanics, the movement of the knee. Those are a bit more troublesome. Not beyond resolving, but they tend to be a bit trickier to sort out. Before we move on from structure, and heck, there could be a whole lecture just on that, but I'd like to take a second to take you on a little tour, if you will, of proprioception. Now, some of you may have heard that term before, but I love Jill Miller's explanation of it. It's your anatomical sobriety test. So your ability to perceive and sense where your joints are, where your limbs are in space is dependent on proprioception. If I were to ask you to close your eyes and to bend your knee to 90 degrees and stop it when it got to 90 without you being able to look to tell, you'd be able to do it. And you've got to ask yourself, well, how do you know it's at 90 if you're not looking at it and then just stopping when you see it get there? Well, you don't have to rely on the visual feedback because of the joint position feedback sense that's provided to you by these proprioceptors. And there's a ton of them. We're not going to go through all of them now. But histological studies, which is basically stick the meniscus under a microscope, let's see what's there, show us that embedded within these structures are some of these proprioceptors, particularly the Paxinian corpuscles. As you can see, I'm going to drop the Google pin on it. There you go there. And the Ruffini endings just above. And they all have slightly unique features in the way as far as what stimulates them and how quickly or slowly they adapt. But I'm going to just give you an analogy here, which I think hopefully will illustrate quite nicely what's going on here. And that is, when you've had an injury, pain and proprioception tend to be inversely proportional. So the more pain goes up, the less proprioception you have. And the more that you can improve proprioception, generally tends to lead to an amelioration and improvement in your pain. And the ideal here is that you want to have precise location switched on at all times with respect to your knee. But the opposite, if you don't have any location, if you know where your knee's at, and there's a few things like pain, like swelling that will pollute this, you're in trouble, because it doesn't matter how good your brakes are, if you've got really strong muscles, if your body is unable to sense if your knee's heading into a car crash and it doesn't know that's happening, you can't push on the brakes. And that's a nice analogy here, is that the worst proprioception is, it's like having your windshield steamed up, right? You can't see. you're only alerted to what's happening by bumping into things, crashing, hitting the hard shoulder, coming off the road, all those kind of things. And some of the techniques, the exercises, the movements we're going to do is almost like getting the windscreen, the windshield wipers up and just clearing the fog, clearing the mist, restoring that precise location so that you have that immediate instantaneous feedback of where your knee's at, so you can hit the brakes when you need to. All right, well, thanks guys for sticking with and taking a little tour through the meniscus there. I hope it's given you a better understanding of the structure, the makeup, what exactly the meniscus is, and some of the unique traits that both the medial and the lateral have. I just wanted to finish up here to bring it back to some actionable points with respect to prehab and how you might go about protecting your meniscus and proactively trying to prevent injuries where possible. And I've just tried to condense this into 3 actionable points. I often explain the difference between static and dynamic stabilizers, or static and dynamic structures. So dynamic is essentially being anything that contracts the tendons, the muscles primarily, and static being things such as cartilage, ligaments, anything non-contractile. And keeping the scaffolding strong is essentially referring to the concept of maintaining good strength through the muscles that support your knee. We know the quads that are shown in the picture there are a big dynamic shock absorber of the knee. And to put it simply, the better your quads are at shock absorbing, at attenuating load, at taking the stress, it's going to help to spare your meniscus, the static shock absorber, if you will. So that's the first thing. The second point is to turn on precise location, drawing your attention back to that proprioceptive slide that we went through before. And as far as how you go about doing that, well, in an acute sense, if you have pain, it's using and swelling, it's using strategies to reduce pain and swelling. There's obviously a number of those. Often we use the PRICE acronym: protect, rest, ice, compress, elevate. Not just for the sake of getting rid of the pain and the swelling, but also because we know that, again, going back to that inverse proportion, that the more the pain and the swelling go down, the more the proprioception will automatically increase. So it's trying to get back into that positive cycle. From a preventative point of view, we can help to improve precise location by actually doing a lot of the proprioceptive exercises as such, and actually to a degree some of the myofascial or the self-release type techniques, using the therapy balls, using foam rollers, etc. And we'll go through that in more detail in another lecture. But the final point, clean upstairs and downstairs. As you can see in the picture, the kinetic chain, that what goes on above and below the knee really dictates what happens at the knee. See here in the picture that we're just dragged in to a position, a disadvantageous, potentially injurious position, by virtue of the fact that the ankle is maybe collapsing down and we don't have good control around the hip and the pelvis. That's what I mean by cleaning upstairs and downstairs, and not just getting myopically focused just on where the pain is if you're in knee pain. But preventively speaking, obviously we're not talking about having pain, but we want to address, really have great pelvic, lumbar, trunk, hip stability, and good control at the foot and the ankle as well.